Oh, I'm National Press Foundation President Ann Godlasky, speaking to you from NPF's Evelyn Y. Davis Studios in Washington, D.C. Thank you for joining us for this webinar, What to Know About Treatment-Resistant Depression, sponsored by Johnson & Johnson. Treatment-resistant depression has received increased attention lately, and here to help journalists learn the latest are some renowned experts. Going alphabetically, I'd like to welcome Maurizio Fava, Psychiatrist-in-Chief at Massachusetts General Hospital, where he founded and directed its depression clinical and research program for 24 years. He's also Associate Dean for Clinical and Translational Research and the Slater Family Professor of Psychiatry at Harvard Medical School. Dr. Lisa Harding, Assistant Clinical Professor in the Department of Psychiatry at Yale School of Medicine and Medical Director of the Mood Institute, an outpatient psychiatric practice dedicated to treatment-resistant depression, especially in underserved populations. Courtney Harris Bond is a staff writer covering health for Philly Voice, with a particular focus on mental health and health inequities. She was also a 2018 Rosalind Carter Fellow for Mental Health Journalism. And Dr. John Pume is Chief of Psychiatry at Foundation Psychiatry PC in Atlanta, where he provides consultation services for Piedmont Atlanta Hospital, and he's also a diplomat of the American Board of Psychiatry and Neurology. Thank you, panelists, for being here to share your expertise. And for everyone tuning in, you can submit questions for these panelists at any time using the chat or Q&A feature, and we'll get to as many as we can. You should also feel free to follow along with the conversation at NatPress. Dr. Harding, let's start with you. So I know treatment-resistant depression is not in the DSM-5, but is there a generally agreed upon definition?
Yeah, thank you so much. And thank you to those who are joining us. Treatment-resistant depression is a very interesting concept because when we think of where science is and we think of where psychiatry is, we are living through this renaissance of where in the past, I say within the past 10, but really the past 5 years, we have newer drugs with different targets. And so is it that we have just not elucidated all of the possible etiologies or causes of depression? Or is it that there is this thing called treatment-resistant depression, because we still don't know yet this multifactorial etiology of depression to target all of the causes of depression. So for clinical trial purposes, we have a consensus definition, which is a patient that has not responded to 2 or more antidepressants at adequate dose and duration within the time frame of a current psychiatric depressive episode, as defined by the DSM-5 criteria. And so it is this concept, I think we all struggle with it as humans, of when human beings are suffering. Forget a textbook definition, we treat real people. So I think sometimes we conflate the things that we do for research and clinical trials and really looking at strict science, which is very different to people suffering. One of the things I encourage the residents when I teach them is that the DSM is really for the structure of your learning. When you have a human being sitting in front of you, it is good for you to think about symptomatology and not giving a patient a medication for every single thing they complain about, but really grouping those symptoms into syndromes. And that's really the purpose of the DSM. The DSM is never meant for us as clinicians to sit down and stuff patients into little boxes for a diagnosis. So I hope that's helpful.
That is, thank you. And Dr. Fava, now you have not just, written the book on psychopharmacology, you've written 8 books on psychopharmacology. So from your research, could you explain the causes of treatment-resistant depression? What's happening in the brain?
Well, I think that, in the case of depression, I think, Dr. Harding is absolutely right. The heterogeneity of depression is probably a significant contributing cause to resistance, in the sense that we have traditionally used what we call monoamine-based therapies. That is, therapies that are based on modulation of monoamines like serotonin, dopamine, norepinephrine,
Mm.
And those treatments, in some ways, were fundamentally very similar. And a substantial number of patients will not respond to those therapies. In fact, in the largest clinical trial that we have ever conducted in depression, the STAR-D trial, only 1 in 3 patients remitted with a standard antidepressant treatment. Now, Dr. Harding is absolutely right that from a regulatory standpoint and a clinical trial standpoint, we tend to consider resistance, the event of not responding to 2 or more antidepressant trials. But if you're a patient and you've tried an antidepressant for 3 months with no response, in my mind, it's already a case of resistance. And that's why as a clinician, I start thinking of next step strategies after the first failure. I don't wait for 2 or 3 non-responses. Now, the biology of treatment-resistant depression still remains to be fully elucidated because of that heterogeneity that has not been figured out well.
Thank you. And Dr. Tumay, let's go to you next. As a clinician, as someone who's, treating patients with this, on a daily basis, how do you go about, to go with? I know that there are several kind of different avenues that one could take.
Yeah, I'm sorry, Anne, I lost you for 1 second. How do I go about?
Oh, I'm sorry. How do you go about determining the course of treatment?
Oh, okay. Well, what you aim to do in the first interview, the first evaluation, what you aim to really do is establish a therapeutic rapport, but also arrive at some form of a diagnosis. We use the DSM-5 now, and then you start your treatment, which these days could include, medication and possibly psychotherapy. Now you track the outcomes. So we used to say, let's wait 6 to 8 weeks. Now we want to see, according to some studies, within 2 weeks, at least 25% improvement in the patient's symptoms. So we have specific scales that we use. Some of these can be objectively done by the clinician. Some can be done by the patient, where they fill out certain scales, PHQ-9, the patient health questionnaire, the Hamilton Depression Scale, and so on. And we want to see, certain results. We divide those into, for example, response and remission. So we want everybody to be eventually close to no symptoms, asymptomatic. Like Dr. Fava said, that less than a third of patients are going to achieve that with 1 antidepressant. So with their first trial. So the goal is to get everybody to remission, but we also look for response, and we define that as a reduction in the symptoms by 50%. So according to whatever scale you're using, you want to see those symptoms go down by 50%. And then you're kind of walking through an algorithm, let's say, of what your next steps are. You always have to reassess. Was the diagnosis accurate? Did I miss something? But if it's still along the course of depression, then we can use the results of, for example, STAR-D trial and other studies we have in the field to determine the next treatment. But we want to see how that first antidepressant goes, and then we reach a fork. Do we, if they have not had an adequate response, do we augment with another medication? Do we switch to a different antidepressant, and so on? And we keep moving down that algorithm until we hopefully get them to remission. But that STAR-D trial shows it could take probably 67% of people are going to require going through a 4th trial before you achieve remission. So but the short answer is you basically reassess at every visit how they're doing, how the medication is working, and then you have to decide each time, do I want to continue? Do I want to change the dose? Do I want to switch, augment? And then, of course, we get to newer treatments of neuromodulation, things like transcranial magnetic stimulation, and so on.
Thank you. And Courtney, you're so important on this panel because you speak to many people with treatment-resistant depression as a journalist, and you've also written about your own experience in dealing with it. So based on your collective knowledge, you know, I feel like what we've heard from the doctors hints at, although we have not said explicitly, like just how long of a process this can be in terms of finding, you know, kind of the right treatment. How do patients deal with that? And is there something that you think that reporters miss when they're covering treatment-resistant depression?
I think in talking to people who experience depression, especially treatment-resistant depression or chronic depression, there's what people miss is that when you're depressed, your executive functioning is lower than it would normally be. So figuring out how to find providers, how to access care, how to deal with your insurance, all of these things are, you know, much harder for you to do. So every daily task is harder when you're depressed. So, and the other thing is there's a lot of socioeconomic classes that just aren't able to access these things at all. So there are a lot of barriers to care for people with depression, including just being depressed and not being able to figure out where to start. So I think that's something that reporters should keep in mind when they're reporting on these stories, is that just the first steps alone can be just very difficult to take. Even just finding where to go, the first steps. I often hear that from patients.
Thank you for bringing up access. Dr. Harding, given your role at the Mind Institute, I wonder if that's something that you want to address. Are you seeing, are we seeing differences in access based on population, geography, all those sorts of things?
Absolutely. So I'm an assistant clinical professor at Yale. So in that role, this is my researcher role. So that's my researcher hat. That is the reason I transitioned. So I only teach at Yale, and the bulk of my clinical work is in the community. And I am an interventionist. So I do electroconvulsive shock therapy, transcranial magnetic stimulation, like Dr. Toomey was talking about, intravenous ketamine and esketamine, which is the S enantiomer of ketamine, and it is delivered through a nasal spray. From 2014 to 2017, the Yale School of Medicine published its internal data, and they treated 2 patients of color, 2, with intravenous ketamine from 2014 to 2017. They then subsequently published other data to look at 2017 onward that was published by Dr. Sinha. It is interesting, and I can take the entire hour because I can present on the bias in medicine. But there was a paper by Loveloy in 2014 that talked about interventions across specialties. We're talking cardiology, immunology, oncology. Physicians look at patients of color and they don't think that they can complete the informed consent process for an intervention. And also, they'd automatically assume that they wouldn't be able to afford it. You know, I think Courtney hit it on the head. It does not matter. We can have all of these wonderful treatments. If people don't access it, this is the exact reason why we see that depression is the leading cause of disability worldwide, not only in the United States. And these are socioeconomic, they have socioeconomic implications. You know, to break this down to the day-to-day level, our postal workers, or Amazon delivery drivers, or grocery store workers, people that don't have the means to even live with 2 or 3 jobs, then they're depressed on top of that. How are they accessing care? So when we talk about access to minorities, we have to have a comprehensive conversation about what the minority is. We're talking about financial classes. We're talking about even where you live. One of the treatments is ketamine that is actually FDA approved and covered by most insurances, but you can't drive yourself to and from treatments on the days of treatments. Think about what it is to arrange a ride to come to a doctor's office to get this treatment. So there are many, many, many barriers. And that's one of the reasons why I had this outpatient clinic here. And I take Medicare, Medicaid, and all commercial insurances because I think that's the only way you can access treatment. And then the second part of it is the patient perception. We talk about it, but also it's really hard to talk to minorities getting over things like Tuskegee and all of the things that have been done to minoritized populations by science. And apologies can go so far, but it takes a lot of work. And I call it education, the engagement. You have to get out there to the minority populations and explain to them the utility of these treatments and why it is that engaging with us can really help them get back to living their fullest lives.
Thank you. And that actually goes to a question that we received by email from one of the participants, Marcela, a writer in Mexico. First, she says, most health insurances don't cover the expensive ketamine, TMS, and DBS treatment, and most people cannot pay from their own pocket. Is the government working on some program to help people and the economy since many work absences are depression related?
So that's in Mexico. I'm bilingual. I actually just hosted a conference on Spravato in Mexico, and they're right now, I know I can tell you that they're working on that for especially the esketamine portion of it. So they are working to implement it.
Great. And then she had another question. What is the regulation with the boom of psychedelics, particularly about MAPS trials? Could psychedelics be a good substitution for some of these other treatments? Dr. Fava or Dr. Toomey, I don't know if either of you want to jump in on that.
Sure, I'm happy to.
And for the other listeners, could you explain what the MAPS trials are?
Sure. MAPS trials are with MDMA-assisted psychotherapy. So, yeah, I think in general, I would say that we have to be anticipating that the psychedelic introduction into the market will bring a revolution of how we provide care. There's no question, because the traditional view was what got you well will keep you well. You take a medicine, chronically. If we think about it, standard antidepressants, you have 30% risk of sexual dysfunction, 20% risk of weight gain, 30% risk of anxiety or sleep disturbances. So these are medicines that, you take every day. They were not devoid of side effects, but that was the standard. With psychedelics, you're talking about intermittent delivery of care. So you give a medicine, you have side effects. They can be quite, significant on that day. But then for 3 months, you don't take anything until the next and the next. That's a completely different model of care. And in my mind, can also address the tremendous problem of access, because I think, as Dr. Harding pointed out, we have tremendous problems of access in general. In the United States alone, the government has, kind of predicted by 2025, we would have a shortage of over 50,000 psychologists and 14,000 psychiatrists. There are states in the United States where it's very hard to find a specialist in treatment-resistant depression. It's quite difficult. But these treatments, the psychedelic treatments, we now have, data on a number of psychedelic treatments that appear to be working. An example is the paper by Guy Goodwin in the New England Journal of Medicine that showed that 25 milligrams of psilocybin was significantly better than 1 milligram, and with 10 milligrams in the between. Those studies clearly suggest that there is a tremendous potential of these agents, and we've seen a tremendous growth of biotech companies and companies working in this space. But I do think that and some companies emphasize the psychotherapy component of psychedelics. Others de-emphasize it. They rely more on the promotional synaptogenesis and other biological effects. But fundamentally, in my mind, they will represent a revolution in care. You have to think about it. In 1938, two Italian doctors, and I'm not mentioning this because I'm Italian, but Cialetti and Bini discovered ECT in Italy as using electricity to induce seizures that treated depression. In 1938, the New England Journal of Medicine published an article by the first chair of psychiatry at Mass General, Stanley Cobb, basically saying, well, this is going to be a revolution, and ECT became for 90 years the most effective treatment for resistant depression. Until 2023, when a study, multicenter trial, led by Amit Anand from our department in the New England Journal of Medicine showed that IV ketamine was as effective as ECT in patients who were referred for ECT. So we're starting to see treatments that are extraordinarily exciting for resistant depression. And there's no question that psychedelics are in this realm, but they'll represent also a departure from how we typically treat, because even ketamine is repeated administrations. ECT, it's repeated administration. You don't have administration once every 3 months. That's kind of completely new, but in my mind, very exciting.
Thank you. That's interesting. And I did want to, Marcelo mentioned in the chat, she is not in Mexico, she's in the Central Coast, so I apologize, Marcela. We also have a comment from Gaurav Datta, who asks, rather than framing it as the patient's unable to access care, can we frame it as care not being designed to be accessible to those patients? And he says that he's asking as a molecular neuroscientist and psychological anthropologist and a person of color. Courtney, I'll let you take that one as it involves language, and I know that's something we geek out about.
Yeah, it's a great question. I think that the idea of patients having to access the care and navigate the system, I do think it's maybe that we need to start thinking about it. How can the system help patients access the care better? I think that's a wonderful shift in thinking. I know people I talk to just get completely overwhelmed, and there are a shortage. Even upper middle class, well-educated white people I've interviewed and talked to can't find providers, don't know what to do or where to go. And I think that the idea of psilocybin is amazing too, because even with ketamine, TMS, ECT, all these modalities that potentially can really help people break the cycle of depression, they require such an investment of time and help with transportation. So all of these things are very difficult, but that's a great question. That's what I would have to say on it. Maybe somebody else has more to say.
Yeah, I think I would just add the 2 cents that I think the world tends to get away, or panaceas get peddled. And what do I mean by that? When somebody asks me, well, which is the best treatment of the ones you do? it really tells me how rudimentary someone's understanding is of depression. You know, one of the things Dr. Fava and I stressed about right at the beginning was that this is multimodal. There is no one hammer that's going to fix the tool of depression. This is just another tool in our armament of the things that we can use to treat depression. And one of the things that we don't have a very good understanding is a phenotyping in psychiatry. So those of us, Dr. Toomey, Dr. Fava, and myself, that has been doing this for years, we can look at a patient profile and say, you know what? I've seen this constellation of symptoms together. And in my experience, here's the drug or the intervention that might help you. The treatment with psychedelics is also going to be very cumbersome. Some of the protocols require patients coming off of all of their medications, which is not an abrupt or process that is not without dangers. You know, I have one patient that I enrolled in the psilocybin clinical trial for OCD, and he became suicidal by the time we got him off of all of his meds. So it's, even if it is 4 treatments a year, it's not something that is not cumbersome, because you're going to have to take that patient off their meds, get them back on it, see how they react, the follow-up that's necessary. I think it's a lot of education that's what's missing about, and it's the consumer end of this. Patients don't understand depression. Patients don't understand trauma. Think of the people in this room. How many of us have parents that have gone to the doctor and come back and said, I have this medication, it's for my blood pressure, but can't really tell you much beyond that. You know, and I think informed consent is what I always come back to. I think if patients understand and have realistic expectations of what the treatment is, what the expected possible outcome is, and what the limitation of that treatment is, I think patients will get better, because then they know, you know what, this isn't actually going to help that.
And I think that's where journalists and those listening are so important, because educating the public is, you know, obviously a huge part of our job. So speaking of, we have a lot of international journalists registered for this. I'm happy to say, from Radio Free Asia to Cape Town TV, Swedish National Radio, a number. We have a question from Liberia, you know, talking about how, you know, their people, you know, end up being abandoned and referred to as crazy people, and them not being able to access the care. I wonder if anyone could kind of speak. I know, you know, a number of you speak internationally on this topic. If you could speak about kind of the access and also the stigma that that we're seeing in different parts of the world.
I think it comes back firstly to the definition. I've not done a lot of work in Africa, but I've done Singapore, Malaysia, and Europe, and of course here, and I'm bilingual, so I speak Spanish and English. It comes back to the definition. If you look at the world view of the definition of psychiatry and sort of like where the numbers are, it comes back to the definition. I'll tell you a story. My father grew up without shoes and went to school without shoes, but if you ask them if they ever had depression, no, they played, they did these things. It's such a different concept culturally. And I think we call them madmen. So I was born in the British colony of Guyana at the time. So it's actually Guyana is when it was a British colony. And, you know, that post-colonization era has such an implication of how it is we are viewed, or how it is we view illness. So we can take this all the way back there. In African countries, we have our World Global Health here with Dr. Ted Iheanacho at Yale, and they're really good papers talking about the construct of depression, one, but just again, coming back to the social stigma and definition. Think about psychosis. There are cultures where communicating with the dead is completely normal, where we would view this as psychosis in one culture, it is not in another. Comes back to the concept of depression. It would be really wonderful, again, to get definitions out. My advice to him is to get the definitions out of what sadness are, prolonged sadness. Start at the really rudimentary baseline level explanations of what diseases are. And I think it is very helpful, especially in minoritized populations, to let them know that these are biological illnesses. Because when you start there, they view it in the same way that it starts to break it down. That's just like diabetes, just like the blood pressure problems. The problems of the psyche are also biological problems.
Thank you. Dr. Tume, so we have been talking a lot about ketamine and esketamine. I'm wondering if you could, for everyone listening who may not know, explain the difference between those two treatments. So that's my first question, and then I have a follow-up.
Yeah, so when we're referring to ketamine, we're referring to the IV form that this was used as an anesthetic agent, and eventually in psychiatry we realized that a significantly lower dosage we could use it in the outpatient setting, and of course people get kind of tired and sedated and whatnot, but they can get up and walk out, and but we could we saw that at those low dosages they had a rapid response. Later, just several years ago, I believe it was, I think you said Johnson & Johnson is sponsoring this. Anyway, they developed esketamine. That's just the form of it that is done by nasal spray. So it's easier to do. Someone like me in the clinical outpatient setting, we switched almost completely from IV administration to the nasal spray because it's easier. We don't have to get an IV nurse and whatnot, and so that's the difference. So the first one was ketamine, we're referring to the IV administration, and esketamine is what's branded as Spravato. That's the nasal spray.
And ketamine has been in the news a lot. I mean, prior to stories about the effectiveness for treating these sorts of issues, obviously it was known as more of a party drug, and then it's been in the news recently, not only again for some of the effectiveness we're seeing, but also in some high-profile deaths, such as Matthew Perry and Elijah McClain. Does that impact people? As a clinician, are you seeing any patients bring that up when you talk about treating them with ketamine? Is that something that they're concerned about?
I think anytime you have something in the media like that, it causes concern. It's horrible what we see in the news with the celebrities, and any drug that's going to be able to put someone to sleep, of course, is if it's used and they're near water and they could fall in and basically drown, or a bathtub, that's obviously a huge risk. It can be any sedative, really. So if someone drinks too much and they are in a bathtub, they could obviously die. So propofol we saw in other celebrities, but I think it's all about how you're using it. We do have to be careful of drugs of abuse. I don't like there is a form you can actually prescribe now that someone can self-administer at home. I personally don't like that because I want to be able to monitor the patient, so I only do in office, but we're giving lower dosages, and we're telling them up front that there's a specific protocol. We're going to do this for a few months. In the case of the spray, esketamine, we're going to do it for a specific time. It's very structured. We'll go twice a week, and then the next month we'll go once a week, and then month 3 we'll just go every other week, and then we're done and we'll reassess. So I kind of laid all out there for them from the beginning.
Thank you. And Dr. Harding, I saw you nodding pretty emphatically.
Yeah.
Is there something you wanted to add?
Yeah, shameless plug for myself. So I wrote an article called The Regulation of Ketamine. So ketamine is racemic ketamine. So lots across the US over the past 10 years, there's been a proliferation of these, what we call them ketamine clinics. They do them, it's done intramuscularly, it's done orally, and there are a couple of companies that have done the racemic ketamine intranasally. If you think of my body as the ketamine molecule, I have a left hand and I have a right hand. If you take away the right hand, you have the S enantiomer of the molecule. So the nasal spray is the S enantiomer of the molecule. So they're completely not the same. the racemic ketamine delivered intravenously is used for treatment-resistant depression. Excuse me. Very small studies, oh gosh, some done at Yale, showed that it rapidly relieved depressive symptoms used, as much as 24 hours, including 4 hours post-dose. This delivered intravenously makes it 100% bioavailable. In the nose, it's about 50 to 60%. The reason why myself, and just like Dr. Toomey, I don't do it orally is because I don't think the bioavailability and the way in which it's absorbed in the body really helps treatment-resistant depression. But yes, patients do ask these questions about safety and tolerability, especially minority patients, because it is one thing to have your urine drug screened for a job like a driver, test positive for norketamine versus esketamine. The difference is esketamine is completely FDA approved, and there are now clinical trials. It's the SUSTAIN 3 clinical trial that shows that these patients do very, very well long-term. We have not developed a cure for depression. We treat patients. I know, I saw your head shaking, Courtney. We don't have a cure for depression, so we treat our patients long-term. When I was interviewed by the Wall Street Journal about Matthew Perry's death, I think the thing that I would like people to know is that ketamine is a very safe drug, and it can treat depression when administered in the correct setting. What happened with Elijah McClain is a travesty of life. And you can read some of Paul Applebaum's work. I also mentioned that in the regulation of ketamine, but the correct people have to be able to use ketamine. The police have no business whatsoever using medical drugs as chemical restraints for their job. And I can go on and on and on with Elijah McClain, but I'll stop there.
Okay, thank you. And Courtney, did you have anything that you wanted to add either on this or possibly about I guess the kind of the long-term, going back to the long-term treatment?
I think with treatment-resistant depression, people can get their hopes up that they'll find a cure that ketamine's going to be the magic bullet. I would just say that as journalists, it's good to present these things as modalities, and that often in combination with other things can really help get patients into remission. I've rarely talked to a patient who said, oh, doing ketamine just put me into remission. It's like a combination of ketamine and therapy, or maybe ketamine on top of an antidepressant they're already on that works synergistically in combination with therapy. It's a very complicated thing. And obviously a lot of depression is biological, but it's hard to tease out. It's hard to tease out. Yeah. Oh, and the other thing I would say is just the IV versus nasal spray is really a hard thing for consumers to figure out. It's a very tough one. And I would say from personal experience that the IV is more effective, but I don't want to.
We are doing a clinical trial starting in September. 6 clinical sites in the country. Here in Connecticut, it's this practice here in Milford, Yale. There's going to be one in Oklahoma, one in Texas, the University of Michigan, and Emory University. We are finally going to try to figure out and answer those questions about IV versus esketamine. So a clinical trial is underway.
That's great. And the only other thing I would say is I get a lot of questions from people, how do I find a clinic? And that's another big obstacle for people, is how do they identify a clinic that's safe and reputable?
The ASKP3 answers that question. So they have a directory where you can get the ketamine providers and the ASKP3, and Johnson & Johnson, like Dr. Toomey was saying, does the Spravato, and they have a Spravato treatment center finder on their website. And so for both of those places, you can Google by your location.
And for both, you need to be, it needs to be administered under a healthcare professional. And am I correct that both are for adults 18 and up?
So that's only Spravato. Spravato has the FDA indication for adults 18 and over. Intravenous ketamine is completely off-label, so it's not regulated by age by the FDA. So I have treated patients as young as 16 years old, treatment-resistant depression. Do you remember, Anne, back in the day, we used to say AIDS has no face? I say depression has no face. And so we treat patients that need care. So once a child and adolescent, for me personally, once a child and adolescent psychiatrist is involved and they have a therapist, I have treated patients as young as 16 with IV ketamine.
Okay. And what about ECT and intracranial? Could you speak about those a little bit, or anyone who wants
Is
to?
over the age of 18 as well, and it has contraindications. So those ones, you have to be evaluated by a psychiatrist and meet the criteria for it. ECT is state by state. Usually there are a couple of states where, because it's, the indication, like Dr. Fava was talking about, he was talking about what is called the ELECT-D trial, which was a non-inferiority between ECT and IV ketamine. ECT is the preferred, believe it or not, treatment of choice for pregnant women that are suicidal. Really good efficacy data for depression in older people as well as mania. But in terms of treatment-resistant depression, I have treated someone as young as 13, but in the state of Connecticut, you have to have 2 psychiatrists independently evaluate the person, plus another psychiatrist that's going to administer the therapy. So that's what I mean by ECT laws vary state by state when it comes to age. And in medicine, we treat everything on a case-by-case basis.
And if I can just comment on TMS. We just published in Molecular Psychiatry, the first trial it's called Ascertain TRD, that compared TMS added to antidepressants compared to in a typical psychotic augmentation compared to high doses of an antidepressant. And much to the surprise, patients who would be considered as having treatment-resistant depression, much to the surprise of many of my colleagues, TMS was actually the winner, was the treatment that showed the greater efficacy. And it's interesting to see how kind of underutilized TMS is in clinical practice. And part of it is, I think, is the concept that unfortunately insurance companies determine what is the most popular, or because the more obstacles they put in on the adoption of a treatment, the more difficult it is to access that treatment. So it varies from state to state, but as a field, we've seen tremendous advances in the treatment of resistant depression with IV ketamine, esketamine, TMS, rapid rapid TMS, and now psychedelics. And so this is an exciting time to be in this field. But the important thing is to have the opportunities to lobby for the removal of those obstacles. Interestingly enough, right? When you look at oncology, it's very rare that new therapies are ostracized by insurance companies. It's very rare. But for whatever reason, in psychiatry, for a condition where we lose over 40,000 people to suicide, last year we had over 100,000 people dying of overdose. Depression is a lethal condition, and yet we don't necessarily treat it like we're treating other medical conditions in terms of coverage by insurance. We don't provide the same coverage, and that's why, depending on where you are, there is one treatment that is more accessible than another. It shouldn't be that way. It should be really clinical decision, but it's not the case.
I imagine that some people with depression listening may be surprised, that they've heard a number of you talk about not just managing symptoms, but actual remission. That might seem like totally out of the realm of possibility. For those where you do achieve that, how long, what are the kind of effects? How long is it lasting? Is treatment-resistant depression essentially, a lifelong diagnosis? Who wants to take that?
I can start off with the STAR-D. So the STAR-D clinical trial, I don't know if you remember, about 50 minutes ago when Dr. Fava started, he started off by referencing the STAR-D clinical trial. And after you tried and not responded to 2 or more oral antidepressants at adequate in duration from the STAR-D, by the time you were on the third, by the time you tried and not responded to and gotten to the third antidepressant, you had a less than 20% chance of getting to remission. And that is not even talking about a response. We don't have a cure for depression. In terms of real life, what does that mean? That in about 3.1 months, about 65% of people will relapse into a depressive episode. That was that third of patients from that STAR-D clinical trial. Many of us would have heard, hey, doc, I'm doing everything right, but my depression still comes back. And that comes back to that multimodal way in which treatment-resistant depression happens. There are no long-term trials or any long-term data on intravenous ketamine, but I have patients, my personal patients that I've been treating for years, that we call them maintenance treatment for depression. ECT, there are patients that get ECT monthly, every 2 months, every 3 months, maintenance treatment for life. Spravato, or the Esketamine, I mentioned the SUSTAIN-3 clinical trial that shows patients that chose to continue have been in remission for about 6 years. So it's really a conversation about, again, comes back to informed consent, risk versus benefit versus an alternative versus no treatment at all. So what you're really trying to work with the patient to have is as least symptoms as possible for the longest period of time, because we don't know the true cause of everything that can cause a patient to relapse.
Thank you. I have a million more questions, but I do want to get this one in for Courtney, because I see we only have about 10 minutes left. When you are doing stories on this population, how do you ensure that their stories are told fully and fairly? Like, are there any interviewing or storytelling tips or rules of the road that you would like to share with your fellow journalists?
Oh, that's a great question. One tip I would say is it's often hard to find somebody who's willing to talk about what they're going through. I've had a lot of luck just asking the doctors I'm interviewing for the story, and almost always they can come up with a patient or somebody they're treating who would be willing to speak about their journey, but often there has to be some anonymity. So the more that news outlets are willing to trust the journalists and allow this kind of reporting, the more mental health reporting will get out there. And in terms of just speaking with people who are going through a tough time, I mean, it's the same if you're speaking to people who are, victims of a crime or who are suffering from cancer. You just have empathy, and there's no magical, it's people feel like they have to tiptoe around this subject. It's no different than any other kind of suffering that people go through. I mean, it can be, different, but what I'm trying to say is pain, and we've all experienced it. So I think we can all relate to somebody who's suffering from depression. And any questions you ask, If they're not comfortable answering, they just will say, you know, I don't want to answer that or whatever. And you can always say that if there's anything I ask you, just say, I don't want to, you know, you don't want to answer it.
And just to add, you know, because we're the National Press Foundation, I do want to just add for those, all journalists listening know this, but for those who are not journalists listening, I just want to explain that when we're talking about anonymous sources, it does not mean that we don't know who the person is. The journalist knows who the person is, their editor knows who the person is. They are verified, and it is simply making sure that that is not publicly made public in the article. I'm going back to the Q&A real quick. We have another question from Marcela. She says, "Do you think that a bigger global mental crisis is coming?" So that obviously big question. Dr. Fava, Dr. Toomey, I don't know. Does anyone want to try to take that one? It's pretty complicated, but
the question about avoiding depression.
Well, we could go to that one too. We have another question about, can someone avoid depression?
Because to me, that, you know, it addresses a question from Marcela Toledo. Do you think that a bigger global mental health crisis is coming?
Right.
I thought I tried to address those two together.
Great.
We know that depression, one of the causes of depression is stress. Stress is a risk factor for depression. In fact, during the pandemic, we have seen a doubling, tripling of the rates of depression in general population, particularly the younger folks. So to me, when you say, how do I prevent depression? The approaches, in my mind, to prevention are not pharmacological per se. They're much more psychological, if we wish, lifestyle, because stress reduction becomes very important. For example, we have a center for resilience and prevention at Mass General in psychiatry, and they've done intervention in college students. And what you see is that a significant reduction in stress, improvement in resilience, is accompanied also by a reduction in the mild levels of depression and anxiety. So in my mind, promoting resilience, reducing stress, these are the things that ultimately will help us with lower rates in the general population. Depression, as Dr. Harding pointed out, is multifactorial. There are many causes, but we know there's a classic study by Ken Kendler showing the importance of stress as a trigger for depression. And so I think that, you know, we prevent depression, and not necessarily in pharmacological ways, but in other ways. The question that I think was posed, are we seeing an increase in depression? The answer is yes. Unfortunately, what we've seen is what we call the cohort effect. Phil Lavori, when he used to be at Mass General, was the first one to describe the phenomenon of the cohort effect. The younger populations have higher rates than people born in previous decades. And that phenomenon that was reported in the 80s has continued to be detected. So it looks like our grandchildren will be more likely to suffer from depression than the children. And their children will be, you know, right now we see this cohort effect that we've not been able to bend, modify, or change. And part of it, I think, is the increase in stress. If we think at, people say, hasn't stress decreased over time? Not so sure. If you think about the stress of COVID, the stress of wars, the stress of poverty, the stress of all kinds of stressors that people experience, discrimination, racism, my goodness, stressors are not becoming less, they're becoming more, in my opinion. So if we want to bend that curve, if we want to modify, if we don't want to continue to see this cohort effect, the grandchildren are more likely to suffer from depression than children. I think that we have to address the allostatic load, what we carry with us, reduce our stress, and help others reduce their stress. Because at the end of the day, that's going to be the most important prevention for depression.
Thank you. Let's stay with you, Dr. Fava, because we're wrapping up here, so let's consider this sort of a rapid fire last question. Mainly, I want to get at what's next. So, Dr. Fava, you had mentioned earlier that this is a really exciting time to be doing, to be in this field, to be doing this research. Are there any particular things, particular treatments, particular studies that you are I'm saying particular a lot, that you're most excited about right now?
I think in my mind, I'm excited about all these new, let's call them interventional psychiatry tools, psychedelics, brain stimulation, ketamine and derivatives, the most recent study with AMPA modulators. There was a positive study, again, a glutamate modulator of the AMPA receptors. All these things are very, very exciting. And I think there's no better time to be in this field of interventional psychiatry.
Thank you. Dr. Tume, what are you excited about? What are you watching?
Yeah, I would say neuromodulation like TMS and psychedelics are pretty exciting as well. But I'd probably say those two things I'm watching closely.
Mm-hmm. Dr. Harding?
I would say neither of those two. I think for me, the thing that I find most exciting, because the science has always been there, right? And science is always going to progress first. One of the things I did after I became a psychiatrist is I became a certified yoga teacher. And right now I am in a clinical trial that is studying music and mindfulness in patients to reduce stress and depression and anxiety. So for me, it is the bigger things, like we're finally branching out to prove by science things that we've all known for years. Dr. Fava was just talking about stress and resilience. Yes, there are studies doing that at Yale. And so I think for me, it is such an exciting time in psychiatry, because sort of like this quote unquote non-science that the world views as non-science, but biofeedback and yoga and meditation all have amazing physiological experiences and effects, and now we're bringing those two together. So while we have all this great science happening, we're also looking at the non-traditional things that can help people with mental illness. So I am beyond excited. I used to be an ER physician first, and this is like way better than that.
And Courtney, what are you excited about in covering this topic?
I think just continuing to destigmatize mental illness in general, and continuing to write about mental health in a way that makes it understandable to people and helps them understand what family members and friends may be going through and what they themselves may be experiencing and not knowing what to do about it. So, but yeah, continuing to raise awareness and reduce stigma, and to not make depression seem like such a scary topic to discuss.
Thank you. This has been an enlightening conversation. I want to thank all of you, our panelists, as well as the participants, for the great questions, and the webinar sponsor, Johnson & Johnson, Journalists who are tuned in, if you would like to reach out to one of the panelists, please contact Alyssa Black, ablack@nationalpress.org. And we will be posting the video as well as a transcript and a summary of this session, as well as resources, so links to some of the studies mentioned and other resources for you all to find there. So I hope that that will be helpful. Again, you can find that on nationalpress.org. Our mission is to make good journalists better, which we do through free training. So please feel free to sign up for our newsletter in the chat to know when our next webinars and trainings become available. And I want to, again, thank the panelists and thank you all for participating, and be well. Thank you so much.
Thank you.
Goodbye.